In this photo, the left lung is inflated, normal, but the right lung is collapsed and air is trapped in the two layers of pleural space. This is called pneumothorax. I am Dr. Fatem Tarek, and in this video we are going to talk about pneumothorax. Pneumothorax is a condition in which air or gas is present in the pleural cavity. Normally, pleural cavity contains no gas, but if air or gas is trapped somehow in the pleural space, that is called pneumothorax. It can occur spontaneously or iatrogenically. In most of the times, pneumothorax is spontaneous. Anatomically or for management purpose, pneumothorax or spontaneous pneumothorax can be subdivided into three types. Those are closed type, where mean pleural pressure is negative; open type, where mean pleural pressure is atmospheric; and tension type, where mean pleural pressure positive, mediastinal shift to the opposite side. The most life-threatening subtype of spontaneous pneumothorax is called tension pneumothorax. Most of the patients presents as a case of severe acute breathlessness and chest pain with altered level of consciousness and hemodynamic instability. In the case of tension pneumothorax, the communication between the airway and pleural cavity acts as a one-way valve, allowing air to enter the pleural space during inspiration but not to escape during expiration. So, with each breath, air traps in. Intrapleural pressure rises well above atmospheric pressure. Raised transpleural pressure causes collapse of the lung, atelectasis, and hypoxemia. So, patient presents with severe respiratory distress and reduced oxygen saturation. And as the tension becomes severe, venous return is also limited, resulting in fall in cardiac output and eventually shock. Hypoxia occurs due to shunting of blood through the atelectatic lungs. So, the main features of tension pneumothorax are hypoxia and shock. Diagnosing pneumothorax is not a very difficult thing to do. There are very specific clinical and radiological signs. Patient may present with acute onset of dyspnea or chest pain. On clinical examination, there will be tachycardia, tachypnea, hypotension, absent or reduced breath sound on the affected side with hyperresonant percussion note, and trachea and mediastinum deviated to the opposite side. Still, radiological imaging remains the gold standard for diagnosing pneumothorax. Though radiographic confirmation remains the gold standard, equipments may not be readily available, and if the patient is unstable and the clinical feature strongly recommends or strongly suggests pneumothorax, then needle decompression or chest tube may be required prior to radiographic confirmation, because tension pneumothorax is life-threatening and a simple needle thoracostomy can save someone's life. Three modalities of imaging are used in the diagnosis of pneumothorax. One is chest X-ray, another is CT scan of chest, third is thoracic ultrasound. Chest X-ray is very cheap and simple test, and it can be done on the bedside Chest X-ray shows sharply defined edge of the deflated lung with complete translucency between the lung and the chest wall. So there will be absence of bronchovascular markings, collapsed lung margin, shifting of trachea and mediastinum in case of tension pneumothorax. Lung ultrasound is one of the modern mode of imaging. Examination of the lung with ultrasound reveals two types of lines, A lines and B lines. A lines are the lines of pleural reflection. Initially there is a pleural line, and on a certain gap there are reflection of the pleural lines, that is called A lines. And B lines are like ray-like lines. In the second image here, the one B line, and there are multiple septal rockets. So by definition, A lines are horizontal hyperechoic line of pleural reflection, and B lines or comet tail artifacts are narrow hyperechoic ray-like opacities extending from the pleural line to the edge of the ultrasound screen. In critical care setting, lung ultrasound is very important, mainly to rule out pneumothorax. Normal movement of the underlying lung with respiration produces a sliding or gliding sign. As pleural air would block the visualization of underlying lung, the presence of B lines and lung sliding rules out pneumothorax. That is, if B lines and lung sliding is present, pneumothorax is negative, with a negative predictive value of 100% in the location of chest probe. And ultrasound should be examined in several locations, especially superior, anterior and the lateral chest wall. So absence of lung sliding is very important feature in favor of pneumothorax, but one can fail to see lung sliding when there is contralateral mainstem intubation, pleural parenchymal adhesion, endobronchial obstruction or diaphragmatic paralysis. An ultrasound of a normal lung tissue shows there is sliding movement of the visceral and parietal pleura and presence of seashore sign on M mode. And in a lungs with pneumothorax, there will be absence of sliding sign and there will be barcode sign instead of seashore sign. Therefore, the main utility of ultrasound for assessment of pneumothorax lies in its ability to rule out a pneumothorax. However, lung ultrasound can also be used to rule in pneumothorax by identifying the point where the lung separates from the chest wall. This is called the lung point. This is an area where a normal lung sliding meets an area where no lung sliding is seen and has been termed the lung point. Lung point is highly specific for pneumothorax. It can be seen in mild to moderate level of pneumothorax, but in severe pneumothorax, lung point cannot be seen. It has 100% specificity for pneumothorax. The third test for diagnosing pneumothorax is chest computed tomography. It is gold standard for diagnosing pneumothorax. The next step is treatment. The primary goal of treatment is to restore normoxia and hemodynamic stability and to evacuate the air from the pleural space. The mainstay of treatment for pneumothorax is intercostal tube drainage with water seal device. If patient presents with features of tension pneumothorax, that is mediastinal shift and or hypotension, then intercostal tube should be inserted. If there is features of chronic lung disease, intercostal tube drainage. If the age is more than 50 years, intercostal tube drainage. If more than 2.5 liter Air comes out through percutaneous nasal aspiration, intercostal tube drainage. If pneumothorax is less than 15% of size, then we can observe with no secondary lung disease. The British Thoracic Society recommends intercostal drainage for all pneumothoraxes in patients on a mechanical ventilator. If needle thoracostomy is performed, standard tube thoracostomy is subsequently required for definitive management. And the optimal chest tube size remains unclear. The British Thoracic Society recommends a small bore tube for the initial management of pneumothorax. Because small bore tubes are associated with less pain and bleeding. Surgical treatment. Surgical pleurodesis is recommended in all patients following a second pneumothorax. Pleurodesis can be achieved by pleural ablation or parietal pleurectomy at thoracotomy or thoracoscopy with video-assisted thoracic surgery. And there another mode is bronchoscopy. Bronchoscopic treatment is implanting a unidirectional valve to isolate and close the fistula. Intercostal tube management. First thing is to assess breath sound on the affected side as well as the healthy side. And regular monitoring of oxygen saturation, to use analgesics for relieving pain, flushing with saline if the tube is blocked. Keep the drainage bottle below chest level. Oscillation or singing. Always keep an eye if there is oscillation or swinging present or not. If swinging is stopped, there may be block or kinked. If there is air leak, problem may be in patient or in tubing. And do not clamp. Put daily sterile dressing of the site. Make sure the tubing is in place. Ensure that appropriate level of sterile water is in the bottle. Keep the system closed and make sure that all the connections are taped and ICT is secured to the chest wall. So that's all about pneumothorax. Finally, thank you all for your patient hearing. And if you like this channel, don't forget to subscribe